Let's Talk About Pain, a podcast from the Quebec Pain Research Network. In each episode, we discuss the latest advances in pain research with guests from across Quebec in the health and research communities. Enjoy your listening.
Hello and welcome to another episode of Let's Talk Pain, created in collaboration with the Quebec Pain Research Network. My name is Hannah Derue, and I'm a PhD student at McGill University under the supervision of Dr. Alfredo Ribeiro-da-Silva and Dr. Jeffrey Mogil. Today, I'm going to introduce you to Dr. Marc O. Martel, Associate Professor in the Faculty of Dental Medicine and Department of Anesthesiology at McGill University. Dr. Martel is a licensed clinical psychologist and research director at the Allen Edwards Pain Management Unit of the McGill University Health Center. His current research program primarily focuses on the biopsychosocial determinants of opioid use problems among patients with chronic pain who are prescribed opioids. We'll talk about his background, his expertise in clinical research, and his prospective research both now and in the future. His contribution will be one of a series which seeks the input of various members of the chronic pain community in a discussion on the opioid crisis. Hello, Marc O. Thank you for joining us today on Let's Talk Pain. Today, I want to discuss the ongoing opioid crisis and how it influences individuals living with chronic pain. First, we'll discuss ongoing research in this field, and then the second part of this interview will explore the future of research and healthcare for people living with chronic pain. Could you please introduce yourself in the area of your work?
Yeah, sure. So I'm an associate professor at McGill, and I've been at McGill for 7 years now, and I trained in psychology, and in 2002 did my undergrads in psychology, started to do some pain research with Professor Sullivan, so that's how I got to the world of pain psychology, and then did a PhD in clinical psychology at McGill, working with Professor Sullivan. And I did a clinical internship at the Allen Edwards Pain Management Unit. So that's a chronic pain clinic at the Montreal General Hospital. I did clinical work there. So that's how I got exposed to populations of persons who live with chronic pain. And over the course of my work, my clinical work there and my research, I became interested in substance use problems among persons with chronic pain. And then a few years later, I went to Boston. I did a postdoc there in Boston and kind of continued to do some research on pain and substance use.
Okay, this is very interesting. So you describe a little bit about your educational path. Did you find your interest in pain research along your education, or was your pain interest prior to your educational experience?
Yeah, that was pure academic discovery when I started working with Professor Sullivan, one of the pioneers in the field of pain psychology. I thought that I got intrigued. I thought that this sounds like a really exciting area of work, but also relevant from a public health standpoint, chronic pain. So really kind of got interested in pain, started to read, and then reading and writing on pain, and then I've been in this field now for about 17 years or so, and so that was really how I got into the field of pain, and really also getting this clinical experience was really important to do clinically grounded research, really like clinical work as informed.
So now you're working in clinical research.
Yeah.
Can you tell me about the topics that you and your lab are currently working on?
Yeah, so the primary focus of my research program is examining, as I mentioned, substance use problems among patients with chronic pain. But I have a focus at the moment. I have two parallel lines of research. One of the lines of research right now is looking at the factors that may contribute to opioid use problems among persons with chronic pain who are being prescribed long-term opioid therapy, so opioid medications, further pain. I also have a parallel line of research looking at factors that associate with potential benefits and problems associated with cannabis among patients with chronic pain. But I'd say, a large piece of my program right now is try to get a better understanding of these persons who are using opioids for their pain. We know that some patients benefit from opioids, and we know that there's a subgroup of patients who might be experiencing some problems with the use of opioids. So we're trying to better understand what could be the factors that contribute to these problems. Could be psychological factors or potential biological factors that might contribute to.
So this could span so many different factors that play into this really complex relationship between all of these variables. For both the lay audience and for those who might be interested in academic research in your field, could you tell us a bit about the techniques and tools that you use to investigate this field?
Yeah, sure. So as a clinical researcher and as a clinical psychologist, like many of my colleagues, and we like to use self-report instruments. So basically, for instance, questionnaires that people will be asked to complete, assessing a number of features or symptoms and states. So it can be psychological states, personality characteristics. So these can be assessed using self-report measures, questionnaires. But I also use, as a clinical psychologist, I'm familiar with diagnostic interviews, so clinical interviews. So we use in my lab some clinical interviews, for instance, structured clinical interview for DSM-5. So these structured interviews are designed to kind of assess potential mental health problems among persons who live with chronic pain based on diagnostic criteria from the DSM. The DSM refers to a diagnostic manual of mental health problems. So we use diagnostic interviews. We are really interested in knowing how people feel, think, behave, not just in lab settings or in clinic settings, one very specific single time point. I've always been very interested in conducting research in people's daily life, in the context of their daily lives, their natural environments. So for that reason, as part of my research program, I've for several years been using what we call ambulatory assessment methods. So basically tracking people in their daily lives using some people use term like ecological momentary assessment procedures. So basically trying to using some diaries and questionnaires, can be electronic questionnaires on their smartphones or computers, just assessing, for instance, pain, mood states, sleep, cravings, withdrawal symptoms in people's daily lives on a day-to-day basis. So let's say following people like over 2 weeks, for instance, and taking like multiple measurements of how they think, how they feel, how they behave. And so this is pretty rich. It leads to more generalizable, let's say, kind of assessments. So we take more measures. So we know that there are a lot of day-to-day fluctuations, for instance, in people's levels of pain. On some days, pain is higher than some other days. We know that sometimes people are more anxious on some days. They may have different reasons why they're more anxious. Can be interpersonal stressors, family stressors, work-related stressors. So mood, sleep fluctuate on a day-to-day basis. So that's why these methods, like these ambulatory assessment methods and EMAs, are really powerful to kind of really capture these day-to-day dynamics and the associations between these variables. And again, with ambulatory assessment, we can also assess other, like some biological markers, saliva sampling. We can ask people to provide saliva samples. We could use actigraphs to track like sleep patterns. So this is like a family of methods, ambulatory assessment methods, that are really kind of powerful and useful to get like a good snapshot of how people do in their daily lives. This is such an overwhelming amount of data that you can
capture in order to get to the bottom of what's underlying the ongoing opioid crisis and how it influences the population of people living with chronic pain. And I think one of the main questions that people are going to be listening for today is what you think your take is on the main factors that would increase the likelihood of someone experiencing chronic pain specifically to also develop a concurrent addiction to opioids.
We've been informed by research and the literature, but also by clinical observations. So let's say over the past, 20 years or so, people have, started doing research in that space on the intersection of pain and addiction. And I'd say that there's a long history of research on addictions in general, whether it's like opiate addiction, cannabis addiction, stimulant addiction, tobacco addiction. But despite the fact that there was quite a bit of research on opiate addiction, most of the research was done on populations of individuals who were using opioids purely for recreational reasons. So what we've learned among populations of persons who live with chronic pain, who are prescribed opioids, let's say they're being exposed to opioids in the context of medical care, research has informed us about a few factors. So perhaps can be broken down. Social demographic factors, for instance, there's some factors that have been consistently associated with opioid use problems. Younger, male, for instance, these have been found to be at risk of opioid use problems. This can include opioid misuse behaviors, for instance, like using more opioids than prescribed, using opioids for other reasons than pain, let's say, to get the euphoric effects of opioids, and then also opioid use disorder. Like opioid addiction is jargon, it's kind of a commonly used term. We use it all the time, of course, in clinic settings and research settings, but the diagnostic term would be opioid use disorder. So like research has shown that younger males, some research on, let's say, those who are unemployed, perhaps tapping into the social determinants of, health, and then opioid use problem, those with low socioeconomic status and disadvantaged populations, something might be at greater risk of misuse. There's consistent research showing that patients, let's say, with high pain intensity, let's say, will be at greater risk of misusing, like those who experience high levels of pain. But what has been really fascinating is that the relationship, like the magnitude of this association has been found to be weak to modest. What I mean by that is that there are a lot of patients with high levels of pain who don't get addicted to opioids. They don't overuse opioids at all. And there are people with much lower levels of pain in terms of pain intensity who then exhibit these patterns of overusing opioids and misusing, and also showing signs of opioid addiction. So that was really interesting. That's something that we've learned from the literature, from studies across different labs, different clinic settings, and suggesting it's not just because people experience high levels of pain that they might be overusing opioids and showing signs of addiction. So it's now, I'd say, fairly robust that there's a number of psychological factors that can have an impact or increase the risk of opioid misuse and opioid addiction. So a lot of studies have shown that those, let's say, who have like ongoing active mental health problems, like major mood disorders, so major depression, for instance, those with major anxiety disorders are increased risk of opioid misuse and addiction. And then some people with personality disorder, it's a bit less consistent, but some people with personality disorders work in the space of psychiatry and addiction. They've kind of looked into these relationships. But I would say, like, even a lot of persons with pain do not meet the criteria for major mood disorders or anxiety disorders, like major depression, but they still show some subclinical, signs of depression and symptoms of anxiety and depression. So this has been quite consistent, like some what we call negative affects, so symptoms of anxiety and depression associated with greater risk of misuse, and it's like other psychological features, I would say. Catastrophic thinking has been linked with patterns of misuse. I'd say probably one of the two most consistent predictors of misuse and addiction is having a past history of addiction, of non-opioid addiction. For instance, those who have a past history of alcohol use disorder or tobacco use disorder or stimulant use disorder, these folks, when they carry this history, they have, this risk factor that increased risk for, opioid use disorder. Those with, past histories of traumas. So this is also an important risk factor. Unfortunately, there's a high prevalence rate of trauma history among persons with chronic pain. And this has also been found to be a risk factor.
So I have a bit of a follow-up
addiction.
question to that. Specifically, a lot of people wonder whether you can discern nature versus nurture, and I think this is probably the worst question you're going to get because it's the hardest one to answer. How much would you say of these features that kind of contribute to the greater likelihood of developing opioid misuse or opioid addiction behaviors is to do with nature, and how much would you say is to do with sort of the nurture component?
Yeah, it's well, I mean, I don't think I'll have like a complete answer here, but I mean, it's similar to other areas like mental health, let's say, and medicine, and some people might have predispositions to developing certain conditions or problems, for instance, and they will develop it, and some people won't, and depends on environmental experiences. And so, what I would say is that just building on some of the factors the risk factors that we just talked about, like we have, there are a lot of persons with chronic pain who have some pre-existing vulnerability factors. I would say like these prior past histories of traumas, and can be physical abuse, sexual abuse, or any other major traumas and post-traumatic stress disorders, these types of traumatic experiences, and they are being prescribed opioids, and they won't show any problems. They will won't show any signs of misuse. They won't develop and show signs of opioid use disorder or addiction. And so really that speaks to some of the potential protective factors, you know what I mean? That, there are a lot of resilient people out there, and a lot of people who can really, cope with some struggles that they may have experienced, and then never kind of show any signs of opioid use problems. So perhaps they've acquired, or they've been exposed to, they've shown some resiliency, or they've been surrounded by some social environments in which they were able to kind of get some support, and it worked out well for them. And I'd say other types of predispositions, we know that the brain, the central nervous system, plays a role in potentially developing opioid use problems, for instance. So those folks who use opioids, or get exposed to opioids, they use opioids for a while, there will be some changes in the nervous system that will certainly might increase risk for opioid addiction. And we're equipped biologically to kind of, we have a system, the reward system. Opioids, they have these addictive properties, and we know that there are some central nervous system mechanisms that probably play a role in leading to addiction. But yet, like, despite all having to some extent the same nervous system, and a lot of folks were, same age, same gender, same sex, same pain condition, some will develop opiate addiction and some won't. So it's really probably really like a bio-psycho-social type of framework and angle that we must have when we try to kind of have an understanding of
this is incredibly
multifaceted,
and I think it warrants further investigation, so I'm glad you're looking into this. I think one of the things that we often overlook when we're having these conversations about chronic pain and opioid addiction is these protective factors that you alluded to before. So resilience is one of them, but what are the other components that maybe the chronic pain community or the community at large should know about in terms of how people can protect themselves if they have chronic pain from experiencing an opioid addiction or misuse behaviors?
I'd say like so far, and like again, many other areas, we've been trying to we focus primarily on the risk factors for certain conditions or problems, in this case like opioid use problems. But research on the protective factors has lagged behind, but we know for sure, let's say, that it's been shown that those who score high on measures of positive affect, for instance, those folks who are enthusiastic, optimistic, and cheerful. And this can be measured using scales, diaries, and these folks tend to showing like less opiate cravings and less opiate misuse behaviors. And it's important to understand that negative affect, let's say symptoms of like low mood, symptoms of depression and stuff like that, negative affect and positive affect are not two sides of the same coin. So you get a lot of people who are not necessarily like scoring high in negative affect, they're kind of neutral, but they're not necessarily showing a lot of positive affect, right? They're kind of neutral on that spectrum. Research has shown that those who are more, high, scoring high in positive affect, they tend to do better. And so that would say that is, whether it's resiliency or just like positive outlook on life, or, there is something with positive affect that is certainly playing a protective function, buffering the risks. But then that's at the patient specific kind of level. I'd say that at the clinical level, there are some clinical strategies that can be used to mitigate opioid risk, related risks. So for instance, there are been some opiate guidelines that have been developed, dating back in 2006 and then 2017, McMaster University and Canadian Opiate Prescribing Guidelines, 10 recommendations and ranging from covering different kind of areas. So basically patient selection, who should be, perhaps considered for opioids and who perhaps, should be carefully monitored if prescribe opioids, and the type of opioids being prescribed, and what to do if opioid use problems are being observed. And so following guidelines is probably, I would say, like one way of just mitigating risk. So guidelines, for instance, have emphasized, and this is really important, that opioid access is really important. So even if people present with certain risk factors, doesn't mean that it should not be prescribed opioids, but it's important to assess before prescribing opioids potential risk factors. Screening, in other words, that's a word that a lot of people use, screening for potential opioid-related risks. So, this can be done with existing scales that have been published in the literature. These, opioid risk screeners have been extensively used in clinic settings in North America. And then basically it informs treatment decision, right? So like those at higher risk, well, they're being given a consideration for opioid. But then what does that mean is that clinicians should periodically monitor these folks just to make sure that, they don't dabble into misuse, and then, just making sure that they're more closely monitored. And then the opioids, what kind, opioid, short-acting opioids, that kind of recommendation has been made, and then not in terms of doses, so this is a consistent, robust finding. So higher the doses, higher the risks. This has been shown like several years ago. It's very consistent, and so there's a linear association between opiate doses and opiate mortality, which we can talk a bit later on, but let's say higher the dose, higher the risk. So yeah, I'd say guidelines are following guidelines for clinicians. So they're really important clinical strategies. And then, there are other kind of protective or clinical strategies that can be used. There are some psychological interventions. So education, for instance, really making sure patients understand like the potential benefits and the potential problems with opioids, getting some education and psychoeducation about like what are the potential risks is important. And some brief psychological interventions can also be used with some persons, like some patients are prescribed opioids. So basically how to cope with opiate cravings, how to cope with pain flares when they have flares, instead of turning to opioids, perhaps. There are other tools, so self-management, right? So this has been documented in literature. So trials have been done in that space showing the potential effectiveness of these interventions for people who are being prescribed opioids. Some psychological interventions can be beneficial, and what to do if people then should engage in repeated, let's say, patterns of opiate misuse, if they don't benefit any more of opioids, if they have like major side effects and they want to lower their doses of opioids. So interventions have been described in the literature that can be used as a way to mitigate, again, to come back to your initial question, to mitigate these risks.
There's a lot of discussion, not only in the academic community, but also in the general layperson audience about the opioid crisis and where chronic pain fits in this conversation. So I wanted to ask, if there's anything that you wish that the general population knew from your position with your education, your background, and your clinical experience about how chronic pain plays a role in an individual's relationship with opioids.
Very important question, and people sometimes hear only like certain dimensions of the story around opioids. It's really important to have like a balanced perspective on opioids and really understand that there are potential benefits from using opioids, for sure in the context of acute pain. And this has, like opioids have been prescribed for acute pain, so after surgeries, after dental procedures, or acute pain relief, but also for acute for chronic pain. There's been like 96 randomized controlled trial, probably now more, but there's been some systematic literature reviews examining all these data, and opioids have been found to be superior to placebo in terms of pain relief for reducing pain. So it's important to understand that from anyone who would be considering opioids, that the magnitude of the pain reduction compared to placebo is not very high on average across all patients. Again, clinicians are not treating the average patient, but if we're looking at all these data from close to 100 trials now, opioids will reduce pain over placebo from, let's say, 0.69 points on a 0 to 10 scale. So a bit less than 1 point on a 0 to 10 scale in pain relief. So it's not a large a pain relief, but it's still a relief, accompanied with modest improvements in functioning. The problem, what people should also know, is that opioids, like these trials, most of these clinical studies have been conducted for not more than 3 months. So we know that opioids are superior than placebo for a short period of time. For sure, within 3 months, it's unclear whether these benefits are sustained for longer periods of time. Yeah, again, come back to this balanced perspective. So there are potential benefits of opioids. There's an abundance of anecdotal evidence, patients telling us that opioids work for them. They've been using opioids for several years and they still work for them. So this is really important. The persons with lived experience, so we gotta listen to what they're saying in addition to these trials, right? So, and there's now consensus, I would say, for those folks who've been using opioids for years and years, and they report some benefits, and it's probably more advantageous and less risky just to maintain them on opioids rather than discontinuing opioids because of some of the potential problems that have been discussed either in the media or in the literature. And these problems, well, I mean, what people should know, we've already been talking about potential problems primarily in terms of opiate misuse and addiction, but these misuse estimates, like the prevalence, in the literature has been around 30% of misuse. Let's say episode, like patients will show some episodes of misuse. Addiction is much less common. There's been some estimates of 10% of people are using opioids, long-term opiate therapies on a daily basis or near daily basis will the opioid use disorder. We're talking about like not the majority of patients will show these problems, though. I mean, this is still important because misuse can lead to health-related problems and can contribute to problems in families, and so this is still a clinically significant set of problems. And then the like side effects, for instance, of opioids, even if people don't, let's say, have misuse problems or addiction, they can have like somatic side effects. What I mean by somatic is like dizziness and concentration problems, so cognitive problems, so these can be clinically significant too, like nausea, interferes with daily functioning. So this needs to be considered by the patients and the clinicians when in terms of decision to continue with opioid therapy or not. But what I would say is that, to end on this question, what people should know is that what we hear about the opioid crisis, because this was one of the key topics of your podcast interview here. When you talk about the opioid crisis, the opioid crisis, the opioid-related deaths, that people have heard about in the media, in the literature. The Public Health Agency of Canada, this is a serious agency, obviously. Their data clearly show that about like 75 to 80% of the opioid-related deaths involve illicitly manufactured fentanyl, for instance, so non-pharmaceutical opioids. So the vast majority of these deaths were among those persons who were using opioids that was not prescribed to them, or illicit opioid users, so not persons with chronic pain who were prescribed these opioids. So again, you don't want to minimize the potential issues and clinical consequences of opiate misuse and addiction, but when it gets to opiate-related deaths, this is really important because there are a lot of stigma, a lot of persons with chronic pain who report, and I've had collaborations on that, like showing like patients report feeling stigmatized by this opioid crisis, because the vast majority of these deaths do not occur in persons with chronic pain who are using opioids in the context of medical care. So yeah, I'd like the general public to know this. This is a very important distinction in terms of population.
I think one of the main
opiate
themes
users
that keeps coming out during this discussion is that we have a lot of nuance in this field. There is a remarkable heterogeneity in what we're looking at and the situation that we're dealing with in the present. But I want to shift towards, rather than discussing the opioid crisis and clinical management of chronic pain now, instead focusing on what the future of healthcare and research concerning opioids and chronic pain could be in the future. So I want to start by asking, how has research in the area between opioid addiction and chronic pain advanced since the beginning of the opioid crisis? Has this influenced your particular area in the chronic pain field? Give us sort of a past to present.
Yes, we've learned a ton of things on pain and addiction over the past, let's say, 2 decades, and in large part on these risk factors for opioid use problems. We've also learned quite a bit on some of the potential interventions or clinical strategies that should be used to mitigate these problems. And then, so I'd say there's some what the future holds and where this whole era is going. And I'd say at this point is, I think still more research needs to be done in that space of who's at risk, and for sure, but really try to kind of how can we help people, for instance, to better understand who might benefit, let's say, from certain interventions, to lower opioid doses. So, for instance, we know that opioid agonist treatment is a first line among illicit opioid users. So buprenorphine naloxone, for instance, is one of that's the first line intervention for illicit opioid users, and methadone second line. But the bulk of that work has been done among illicit opioid users. So this is where we're at now. So we have a lot of persons who will continue to use opioids. They will be maintained on opioids. They're doing fine. There are a lot of patients who are telling us that they want to lower their doses. So we need to better understand, whether these interventions, let's say, opioid agonist interventions, so for instance, Suboxone-assisted dose reduction or gradual opioid dose reduction, who benefit from that, whether there are some patient-specific factors that might impede, these dose reduction efforts, who struggles during these dose reduction efforts. This is a really important area. We know that some patients are anxious about reducing their doses, and they might worry about the potential flares, the pain flares, the withdrawal symptoms, and so we need to know better in our population of patients who are being prescribed opioids. What are the factors that impede these dose reduction efforts? So right now, that's in terms of interventions.
So I want to get into the world of
that's where
research
we're
and
at.
a bit on policy. This research that you're doing is incredibly valuable and necessary because it's understudied in certain ways, like you mentioned, but it's also incredibly resource intensive. And it could be quite pricey to do all of these different tests and inventories, and working with people in clinical spaces. It's quite time and financially intensive, and it takes quite a bit of effort for this. So if you were able to sit down with a major political figure or a policymaker, what would you tell them about your work, its importance, and what supports are required for you to advance your work?
Being exposed to any decision maker or sponsors like funders, I mean, we will always advocate for more financial resources to support our own program of research, of course. But I would say that the bulk of the work that I've been doing, and some other groups have been doing on risk factors for opioid use problem, we've learned a ton. Now, I wish I could have more financial resources to maintain that type of line of work that I do. I wish I would have more financial resources to support students. Students are really like students and research assistants, so highly qualified personnel. That's the term that we use. Like these folks who graduate and then they kind of get in the field of like research, and then they help with executing some studies and analyzing data, and then we need financial resources to kind of financially support these highly qualified individuals. And I wish we would have more support, financial support for disadvantaged students. A lot of them come with a lot of meaningful experiences, prior experiences, clinical experiences in their communities. They can bring a lot to research teams, and unfortunately in academia sometimes we're kind of forced to kind of get students who come with certain GPAs and a kind of a limited number of students because of funding limitations. So I hope in the ideal world, unlimited funding, that we would have support for more students and like a wider variability of students. That would be really terrific. I think where we're at policy, from a policy standpoint, there are really a lot of important things. I'd say that what we've learned that is critically important is that because of this opioid crisis, and as much as we've learned on as much as the research on the risk factors for misuse and addiction has helped clinicians to kind of better monitor and screen these patients and mitigate risks, there major problems occurred in the U.S., primarily in North America, but primarily in the U.S. in terms of guidelines that have been proposed that were useful but misapplied, misinterpreted by some clinicians. What I mean by that is that some, because of the crisis and what they've heard about the crisis, some clinicians, for instance, have decided to abruptly discontinue long-term opiate therapy among some patients, and this was a major. This has been documented. This is a major problem. This led to mental health crises. This has led to patients being in withdrawal, turning to illicit opioid sources to get adequate pain relief, accessing opioids through the illicit route, or might lead to major risks. So this has been a major problem. Some payers, insurers in the U.S., for instance, like they've interpreted some of the guidelines, the CDC guidelines that were published in 2016. They were misapplied, so they had applied some ceiling. As soon as they capped at 90 milligrams daily, because there was a recommendation not to exceed, but it was interpreted as a strict cutoff. So any patients above 90 should be abruptly discontinued, or they wouldn't pay if it was above 90 milligrams. That was a major, major problem. So they were some revised guidelines in the U.S. They tried to rectify this important misapplication of the guidelines. So really, like decision makers, and this is regulators, decision makers, clinicians, the public, this is something that really needs to be understood. Like abrupt discontinuation of long-term opiate therapies, unethical and clinically risky. So that's probably the main message I would make sure to get across for these decision makers. Importantly, really important, and that was more for opioid-related issues, but people have been advocating for decades about pain under treatment, regardless of opioids. I mean, pain has been a major public health issue for decades. about 20-30% of the population, and a lot of the listeners will know that, those who are interested in pain, but about 20-30% of the population is adult population is affected by chronic pain. And accessing high quality pain care or just pain care is a major issue. And accessing interdisciplinary or multidisciplinary pain care is a problem. It's very difficult, long wait lists. So this is certainly more financial resources as well, not just for our own individual research programs, but more financial resource to improve or increase access to high quality pain care is critical. There's been some also disparities in pain care, some disadvantaged populations having a more difficult time accessing high quality pain care. Accessing multidisciplinary pain care, I was saying, not just within a single clinic, but also other, let's say, interventions than medications. So there are a lot of pharmacological interventions that can be used for persons with chronic pain, but there are also a lot of non-pharmacological interventions that can be used and can be beneficial for persons with chronic pain. This includes physical therapy, alternative complementary medicines, psychological interventions. So accessing these types of services, we know that can be very difficult, not just wait lists, but costs. So this is something that policymakers need to know more. Financial support for these types of services is critical for reducing pain, but also reducing opioid-related problems, because most of these opiate problems have emerged from persons, let's say,
so let's say 150 years from now, fast forward to the future, in an ideal world, how do you imagine the care of people living with chronic pain?
Well, probably in line with some of the things that I said, of course, with the access to high quality pain care, pharmacological and non-pharmacological interventions for sure. But beside that, also, like, a world, and this is obviously an ideal world, but may sound cliche, but that's what it is. Like, we all hope as, clinicians, citizens, researchers, we hope that, we would live in a world free of pain and people that are pain-free, of course, but not just being pain-free, free of mental health problems, free of psychological distress. And this is a distinct public health problem. We have a pain crisis. We have a substance use crisis. We don't only have an opiate crisis. We have a substance use crisis. And then we have a mental health crisis. Like, mental health problems are abundant. They're highly common, not just among persons who live with chronic pain. So a world of people with, let's say, with chronic pain who would not be affected by these severe mental health problems, let's say. Some of them do well, but some of them are struggling. A world, let's say, with no suffering, basically. Pain, mental health. A world free of stigma. A lot of persons, not just persons with pain, but pain, opioids, persons with mental health challenges feel stigmatized. So a world free of stigma would be ideal for sure. So that would be certainly an ideal world.
I think this is the end of my questions for this episode. Do you have anything to add?
No, I don't. Thank you very much for inviting me to take part.
Thank you very much, Dr. Martel, for participating in our podcast. Thank you to our listeners for tuning in to this episode of Let's Talk Pain, and we'll see you again soon.
Thank you for listening to Let's Talk About Pain. Don't hesitate to subscribe so you don't miss an episode, and to share the podcast with your friends. For more information, visit our website at qprn.ca or our YouTube channel by searching Quebec Pain Research Network. See you next time.